Hi, my name is Mary Kay Bader. I'm the neurocritical care clinical nurse specialist at Mission Hospital in Mission Viejo, California in the United States. And it's an honor to be with you today to present The Eyes Have It, Assessing Pupil Dynamics using the NPI 300 Pupilometer and the implications for practice. I'd like to thank the organizers of the meeting for inviting me to present today. And also, my disclosures are listed on this slide. So let's talk about who needs their pupils assessed. So patients with primary neurologic disorders, traumatic brain injury, stroke, post-op craniotomy patients, neuroinfectious disorders, seizures, altered mental status, all have conditions affecting the brain, and the ability to assess the brain not only includes the clinical exam, which isn't the most important thing, but pupil exam is part of that. There are other conditions, though, where pupil exam can be helpful. These are called secondary neurological injuries. For instance, cardiac arrest patients who've had a cessation of blood flow and then restoration of pulse. They need to have their pupils assessed. Cardiac surgery, ECMO, COVID-19 patients, and patients with encephalopathy. Assessing the pupil is important, and it involves a relay between the eyes and the back part of the brain where the midbrain is. So when we look at flashing a light in the eye, we have a patient whose light will be captured by the optic nerve. And so in yellow and orange is the optic nerve here. That message is sent back to the same side of the brain and also to the opposite side of the brain, back to the midbrain, where the Edinger-Westphal nucleus is located. Now here, the third cranial nerve sends the impulse back here and here for the pupil to constrict. So it's made up of a sensory component and a motor component. When we assess a pupil, we look for pupil size, we look for shape, we look for reaction. But there are a number of conditions that impact pupillary response. Increased intracranial pressure, ischemia, lack of blood flow to a certain part of the brain, seizures, and metabolic disorders, all can cause changes in pupil dynamics. By using a pen light or a flashlight to check the pupil, we could go in and say, well, the pupils are 4 millimeters, they're equal, and they react. Or maybe we'll say the pupils are sluggish. Or maybe you call 3 of your best friends into the room and say, did you see that pupil react? Because I think I saw that pupil react, but maybe it really didn't. And so pupil exam with a flashlight is a subjective assessment of pupils, whereas a device called the pupilometer can provide the team with objective data. Studies have shown high inter-rater reliability between practitioners. A number of articles have been published over the years that have demonstrated that practitioners don't always agree on pupil reactivity. One particular article published in the Journal of Neurocritical Care in April of 2016 by Dr. Daiwai Olson, a doctorally prepared nurse colleague, showed that inter-rater reliability of pupil assessment was not great. In fact, it wasn't ideal. And when we look at the agreement on fixed pupils between practitioners and the pupilometer, we find that there's 50% disagreement. And when pupilometer agreement with the practitioner assessment, when we look at pupils that are non-reactive by practitioners, only 33% of pupils scored as non-reactive were scored as non-reactive by the pupilometer. So in fact, there was pupilometer reaction. So what does a pupilometer look like? It's a handheld battery-operated device. It has a headrest that connects to it. There's a light that flashes when you hit the right button over the right eye, and the light then creates a change or reaction to the pupil. So once the light shines, the pupilometer records the size of the pupil before the light, how fast the pupil constrict, called constriction velocity, the size of the pupil after the light, and then how that pupil recovers. Now, the readout that you see on the pupilometer, this is for the right eye and the left eye, show you that max and min size of pupil before and after. Constriction velocity is the how fast in millimeters per second the pupil reacts. And NPI, or neuropupillary index, is a mathematically calculated number between 0 and 5, and these numbers have significance. So when we look at trending, the most important thing for NPI, a normal NPI, is 3 to 5. Anything under 3 represents increasing ICP or a difference of 0.7 between the two eyes. The constriction velocity, or how fast the pupil constricts, anything above 0.8 of a millimeter per second is normal. Anything under 0.8 of a millimeter per second represents increased ICP. Let me share with you a case study of one of our patients. We had an 18-year-old female who was in a motor vehicle accident. She had severe injuries to her head. Her pupils were big and non-reactive. Her Glasgow Coma score was 121, equaling 4. She was extensor posturing. She had tension pneumothorax. She had a broken pelvis and other extremity fractures. She suffered a cardiac arrest. She had CPR. They restore her pulse. She goes to CT scan, and these scans of her brain show a very edematous brain. And so she was taken to the operating room, and the neurosurgeon arrived, and he was going to do a craniotomy and put an ICP monitor in, but he said, the patient suffered cerebral herniation. This is a fatal injury. No craniotomy was performed. So she comes to the ICU, where when the nurses assessed her on arrival, they found a female with Glasgow Coma score of 3. She was not on sedation. Her motor movement, she had no motor movement, but her pupils reacted, and they captured this information that's on the slide of the NPI and of the constriction velocity and size. So you can see we do have reactive pupils, and there are differences between the NPI, and there are times when the pupils are barely reactive. Well, the team was awaiting the loss of brainstem reflexes, but the pupils continued to demonstrate reactivity. The nurses continued with their neuroassessment, and on clinical exam by day 3 could see withdrawal to deep painful stimulus. Well, believe it or not, by day 6, she was opening her eyes and tracking. By day 8, she went for the repair of her orthopedic fractures. She was extubated on day 11. And while cleaning the road rash on the back of her, she yelled, ouch, ouch, you, oh, sorry for using that language. And she came back to see us at day 45, completely normal, and had an amazing recovery. But the contribution of having objective data for the pupil was very important. Just last week, we had a patient, I was rounding with our neurointensivist. We had a patient in our other intensive care unit that had suddenly, he had come in 7 days before to our cardiac telemetry unit. He had congestive heart failure. He was on a heparin trip. And during the night, about 6 hours prior, he suffered a hemorrhage event. So he's bleeding. He got transferred to the ICU. And in the morning time, the nurse noticed that he had little fasciculations around his eyes, muscles that were tremoring. And she did an assessment with the pupilometer and found this, where the left eye was a lot, we had a lower NPI in the left eye than the right, and the constriction velocity, how fast the pupil constricts, was very slow in that eye. So the neurointensivist ordered the headband EEG device be placed, and the patient was sustaining seizures. So once again, a change in a pupil and the pupil reactivity led to further assessment by means of EEG, and the patient had sustained a seizure. So what I'd like to do in the short time I have with you is go through some of the research and apply some case studies that might be helpful. So here's a patient when we first started using pupilometer, and we had version 1 in 2003. So this is about 18 years ago. And 3 years into using it, you only really had constriction velocity at that time. The NPI technology wasn't developed until 2011. But in 2006, we had the device, a pupilometer, We had a patient who had a bad subarachnoid hemorrhage, an interventricular hemorrhage. It was a grade 5 Hunt and Hess, grade 4 Fisher. And the neurosurgeon had placed an ICP ventriculostomy in the brain. We had drained cerebrospinal fluid 4 days. And by day 13, they took the ICP catheter out. Now, on that day, her constriction of her pupils was quite normal, 1.2 millimeters per second. But 2 days later, the nurse notices in a morning assessment that constriction velocity has decreased to 0.5 millimeters per second and nothing in the other eye. Now, I don't know about you, but I'm not that good. I can tell you it's brisk, I can tell you it's sluggish, but I can't tell you in a defined way the exact how fast or how slow that pupil's constricting. They did a CT scan, which showed hydrocephalus. They put a new ventriculostomy in. After we drained CSF, her pupils again started reacting. We saw normal constriction velocities, and she actually had a very good outcome. Now, when we look at research in cerebral edema, there are studies that have shown improvement in the NPI after receiving mannitol. There are studies that have explored the NPI in the relationship with ICP. And so if we look at some of these studies, this is a study that looked at cerebral edema, 72 patients, and they got mannitol, and they looked at the NPI 2 hours after the mannitol was given. They found significant improvement in the NPI within 2 hours after receiving the mannitol, and the result remained significant after controlling for other interventions. Another study that was published in 2011 by Chen et al. Was a study with this new aspect of pupilometry, the NPI. And so in this study, what they discovered was that there was a relationship between NPI and ICP, meaning as ICP went up, the NPI went down. And they found that anything above 3 was okay or normal, but anything under 3 represented increasing in ICP. So this was the first study that had come out looking at NPI and ICP and what the relationship was. Another study published by Molly McNett, again, looking at increased intracranial pressure. And Molly is at the Ohio State University. This was done with her and her nursing colleagues. And they found that constriction velocity and the NPI had a negative correlation with ICP. So much slower constriction velocity, lower NPIs were associated with higher ICP. So this study showed that it might be helpful when nurses are assessing pupils to have a device that can quantify the data of the pupil in some way. Here's one of our patients, a 54-year-old male, post-thrombectomy. He had a clot in his basilar artery. The interventional doctor pulled the clot out. And post-op, he was extubated. He's waking up with minimal stimulation. And then a few hours later, we see a difference in this NPI, 4.4 and 3.6, and the pupils have slowed down in its reaction. A CT scan showed hydrocephalus and significant edema or swelling in the posterior fossa. So they put a ventriculostomy in, they drained CSF, and we saw return of pupillary function back into the normal range. Here's a patient that came out of our operating room after a craniotomy. This is a 49-year-old female. She had an aneurysm clip that was in her brain. And the ICP ventriculostomy the waveform was dampened, it wasn't draining CSF. And the nurse was carefully assessing the pupils. And you can see here where at the beginning of the shift, the NPIs are normal, the constriction velocities are normal. But about midnight to 1 o'clock in the morning, we see slowing down of the constriction velocity and a difference of 0.7 between the two eyes at 1:05. The neurosurgeon was called. They got a repeat at 1:30 with a worsening status of the NPIs. And at 1:50, one pupil was 7 and fixed, one pupil was 2.5 and fixed. Did a stat CT scan of the brain, massive hemorrhage in the on the CT. They had to go back to the operating room. NPIs have been studied in traumatic brain injury and shown to correlate. Increasing ICP was correlating with an abnormal NPI. And so this is a study by Jans et al. This is done at Lucerne University in Switzerland, 54 patients with severe TBI. And they found that sustained elevations of increased intracranial pressure was associated with a decrease in NPI. And that if they treated the patient with hyperosmolar agents, they saw normalization of the NPI. If the NPI did not return to normal, it correlated with a very poor prognosis. And this slide shows you the high ICP here, above 20, and a low NPI down below 3. NPI was studied in traumatic brain injury with triage. And here we see NPI was predictive of intervention. Higher NPIs were associated with better outcomes, and a low NPI was indicative of the severity of the injury. Here's a patient from our hospital with a large subdural on the left side. The NPIs, the first one obtained, showed 1.7, 1.9, and within 18 minutes, it went to 0, and he had fixed non-reactive pupils. NPI has been studied in stroke. So in subarachnoid hemorrhage, an NPI less than 3 was strongly associated with delayed cerebral ischemia. And ischemic stroke also showed changes in the NPI. So these 56 patients with subarachnoid hemorrhage, they found that an NPI less than 3 was strongly associated with the onset of delayed cerebral ischemia. And this NPI decreased about 8 or more hours prior to clinical deterioration. This is one of our patients, 40-year-old female with a ruptured large MCA aneurysm. And you can see that the left pupil NPI is pretty normal, but take a look at the right pupil NPI. This patient developed critical vasospasm. So we saw drops in the NPI and drops in the constriction velocity in the side where the spasm was. This article on NPI and stroke, published in the Journal of Neurocritical Care, it's from Korea. They had 10 patients who experienced neural worsening, and an NPI value less than 2.8 showed neurologic deterioration. So again, correlating NPI with worsening edema in stroke. Here's another study that looked at acute ischemic stroke and intracerebral hemorrhage, and found that the pupilometer could be a valuable tool to monitor the worsening of intracranial pathology. Here's an example from our hospital, a 78-year-old woman who was admitted with atrial fibrillation on cardiac telemetry unit. And she had been normal, and then 36 hours later, she's found unconscious. Rapid response nurse was called. They called the code stroke. The NIH stroke scale was 23. The patient's Glasgow coma score was 111. And the pupilometer reading showed no reaction of the pupils and an NPI of 0. She was taken to CT scan after being intubated. There was no bleeding here, but her CTA showed an occlusion of the basilar artery. And what's important to note is that basilar artery feeds the back part of the midbrain. So with the vascular supply cut off to the midbrain, the patient wasn't getting flow, thus she had no pupil reactivity. IV TPA and a thrombectomy was done. When the patient came back to the ICU, her NPIs had completely returned, the reaction of her pupils returned. But then 36 hours later, she had another event where her NPIs went to 0. And on CT and CTA, it was learned that she re-occluded her basilar artery. There are studies that have looked at non-convulsive status epilepticus and showed that right and left NPI were significantly lower in confirmed or possible non-convulsive status epilepticus. This is one of our patients who developed a change in her pupils where we saw a significant drop in the NPIs suddenly, and she had these changes that were indicative of seizure activity. There are other neurologic disorders that are as a result of a secondary event, so post-cardiac arrest, for instance. This has been studied in many studies, Riker and Odo's study. In Riker's study, they found 100% of the patients with greater than 1 non-reactive pupil and NPI of 0. Within 6 hours, they died. So all the patients that had NPIs of 0 died. And that 86% with sluggish pupils, NPIs between 0 and 3 had poor outcomes. In Dr. Mora Odo's study, that was a multi-center study done across Europe, 456 comatose patients resuscitated post-cardiac arrest with targeted temperature management. NPI was unaffected by hypothermia and sedation, but 100% positive predictive value with even one NPI less than 2, those patients had an unfavorable outcome. This is one of our patients, 38-year-old female, has a cardiac arrest. TTM is initiated within 90 minutes. The pupilometer reveals a very low reading initially, but it recovers to 4.1, 4.2. And this is her in rehab who's done amazing recovery. But once again, that NPI is showing us that there could be changes. So in summary, the pupil exam is one component of the neuro exam, and I'm hopeful that I've been able to share with you the importance of using an objective tool in pupil assessment. If you have any questions, please email me, badermk@aol.com. Thank you very much.